There are certain ages where you can still get pregnant. It's just more difficult to do that. There's suggestions that sperm for men in their fifth and sixth decade, in their 50s and 60s, might have some downstream genetic problems. Yes, endometriosis does impact your fertility. Well, you're young, you got time, and that's true, but you won't be young forever. And then at some point, if you do come back later and you're in the same situation, egg freezing is that much more difficult. Very often people think about egg freezing as what they need to do for the first baby. And that may be the case, but as I said in the beginning, my job isn't just to make babies, it's to build families. And what if you want to have a larger family? Right? What if you really always wanted 2 to 3 children? So any patient over 40 that wants to make a baby, we would agree to see them in consult. It doesn't matter where you live, where you are. I would seek some form of consultation to even if it's a virtual consult, even if you live in a place where they don't have advanced technology, just to fully understand the choice of trying naturally versus other options.
Well, hi everyone, welcome back to Black Fertility Agency's channel. If you're new here, welcome. My name is Ekena and I'm the Executive Director here at BFA. So we've been spotlighting fertility doctors, and today we're back with another amazing interview. My colleagues at BFA have raved about how incredible he is, and I'm happy I have the opportunity to interview him. Hi, Dr. Baratz, how are you?
Thank you for inviting me, Ekena. I didn't know that you spoke to my mom before this meeting, but thank you for the endorsement.
Awesome. It's nice to meet you. Before we get kicked off with the questions, I just wanted to read off your very, very impressive biography here. So for our viewers who are listening, who are interested to know who Dr. Baratz is, Dr. Ari Baratz has been dedicated to women's health and reproductive medicine for the past 20 years. He's one of the select few physicians in Canada with the accreditation and the advanced level of training required for the care of people dealing with infertility and recurrent miscarriages. Dr. Baratz attended McGill University for his Bachelor's of Science in Anatomy and Cell Biology, and the University of Western Ontario for his medical degree. After completing his obstetrics and gynecology residency at the University of Toronto, Dr. Baratz was designated by the Royal College of Physicians and Surgeons of Canada with a fellowship in reproductive endocrinology and infertility at the University of Toronto as well. Upon joining CREATE, Dr. Baratz assumed a faculty position in the Department of Obstetrics and Gynecology at the University of Toronto. He's a leader in ambulatory gynecology and surgical education and has mentored many students, fellows, and residents in reproductive medicine. Through CREATE, Women's College Hospital, and the University of Toronto, Dr. Baratz continues his research in medical education in several aspects of clinical infertility and reproductive endocrinology. He's focused on providing patient-centered fertility care. Dr. Baratz has been an executive board member for the Women's College Hospital Medical Staff Association and the Women's College Hospital Alternate Funding Plan. Currently, he's a chair for the Ontario Medical Association Reproductive Biology Section, president of the Board of Directors for Fertility Matters Canada, and Board of Directors Chair Medical Advisory for the Modern Miracle Foundation. Dr. Baratz has been awarded numerous teaching awards, including Foundation Faculty Teaching Award in June 2024 and the Teaching Award of Excellence in May 2024. In addition to all of this, Dr. Baratz was also named one of Toronto's top doctors for the past 3 years. So that's 2023, 2024, and 2025. Very, very impressive. Wow. I do want to add that we shortened that bio a little bit, but the full bio is going to be available in our description. Amazing, Dr. Baratz. So going right into the first question that we have for you here, what inspired you to specialize in fertility medicine, and kind of how do you stay passionate about it?
Ekena, thank you once again for making me feel special and comfortable during this interview. I feel like you know me, but I'll help you get to know me a little bit better. I'm always excited to answer that question, like what inspired me to go into fertility medicine, because I think it actually starts with the end, which is, this is to all of our audiences, you want to feel that your providers, whether it's your doctors or your nurses, are really deeply engaged. And my deep engagement in fertility medicine or in medicine started a long time ago. So I actually remember high school science. learning a bit about biology, learning about chemistry, learning how to interact with people. And I thought if I could find some way of bringing those two items together, I think I'll be passionate for a long time about what I do. And fortunately, through my undergraduate and my medical school training, I was able to continue to incorporate a love of science and a love of being a provider. I didn't know exactly what it was going to look like, but I always
Mhm.
remember learning about cell biology, embryology, and having mentors in women's health that gave me that scaffold, that framework. I was very fortunate to go to the University of Western Ontario for medical school, which Ontario in general is one of the pioneering areas of IVF in North America. So I was exposed to some of those leaders. And as a result of that, I decided that after medical school, I was going to pursue obstetrics and gynecology, which which really is the pathway to reproductive medicine. And then that took me back to Toronto. And in Toronto, again, I was fortunate to have mentors and teachers and professors that showed me both the clinical side and the research side of reproductive medicine, which then led to further fellowship training specifically dedicated to what we refer to as reproductive endocrinology and infertility. One form of that is obviously IVF, but there's other aspects to reproductive medicine. And so I dedicated myself for 2 years to that training, including some advanced training in how to provide medical education. After all of that, I couldn't help but continue to work in reproductive medicine. I was trained to do it. So that's what led to my current practice. You asked me what keeps you passionate about it. And well, that's
Yeah.
easy, making live, healthy babies. I mean, that's the most incredible. I always say my job isn't to make healthy babies, it's to build healthy families, healthy moms, healthy dads, healthy
Mhm.
grandmas and grandpas and great grandmas and great grandpas. So when you can, or even I could say my job is to help make more Ontarians and more Canadians. So when you're part of that process, it's incredible to see that early movements, early decisions, shared decisions can lead to such incredible outcomes. So that's what keeps me passionate about it.
Amazing. Yeah. And I think it's reproductive medicine is just one of those fields where you can see right away the results of your work. You're creating those babies. You see an addition to somebody's family and the joy that you can bring doing something like that. But it's amazing to kind of understand how some of the mentors you've had in your early life and kind of through your education shaped your decision here.
Well,
Um,
I like to make a little plug for the BFA as well, because I think that when you think of the BFA, you think of just from very often you think of the patient experience, like someone wants to make a baby, and we talked all about advocacy. But there's another side to what we're doing, which is maybe we're inspiring the next generation of reproductive medicine providers that come from the BFA community or other communities. I mean, I wouldn't be here if I didn't have
mhm.
that science high school experience. And I actually try to do some grassroots outreach with science students in high schools of different backgrounds, because you never know who will catch that interest and want to pursue what I
Exactly.
do. Because it was so far away. I mean, it was so many decades ago. And in retrospect, that framework was actually part of this long process I've been involved with.
Mhm. Amazing. And now when it comes to your patients and the patients that you see, how do you ensure that they feel heard and supported throughout their fertility journey?
First of all, that's a really good question. It's very important that people feel that they're not in some passive process, but that they are active for a few reasons. One is that whatever journey they're taking, we need them to be part of it, right? It isn't like an operation or a surgery in medicine where you do something to someone and then magically their arm works again. I mean, there's
Yeah.
many moving parts to it. So there's a few terms that I encompass in what I do. I think the first piece is uh, the shared decision making. I mentioned that before. The idea that there isn't only one pathway forward. Yes, we want to all achieve success, which we've talked about as a healthy live child, or maybe multiple healthy live children, but there's different paths along the way, and making sure that when a patient is trying to either raise concern, needs more information, uh, that you can provide that and provide the alternatives and make sure that they're fully understood.
Mhm.
You can show someone the way, but if they don't fully understand why they're doing that or what the alternative is, I don't think you'll have full satisfaction, whether it works or it doesn't work. So shared decision making, and part of that is also exploring patients' feelings, their ideas, their perceived impact on their function, like their daily living, and their future, as well as what their expectation is. Like, what do they think is going to happen here if we go down path A or path B? So what I'm getting at is incorporating the unique patient experience that is not simply an issue of endometriosis or fibroids or polycystic ovary syndrome or primary or secondary infertility or miscarriage, but there's an interpretation that each patient has that adds a dimension. So incorporating that unique experience and highlighting it and saying, look, Mrs. Smith or Mrs. Jones or Mrs. Cohen or Mr. Brown, like these are issues that you're worried about, and I'd like you to understand them a bit better.
Yeah. Yeah, I completely agree, because two people they could both have a diagnosis of endometriosis, but it means completely different things to those two people. So it's great that you really focus on the patient first, versus just really going with the diagnosis. In terms of your sort of philosophy, what do you think is something that's unique about your practice or your philosophy that sets you apart from other fertility specialists?
Well, I mean, going along, expanding on the previous question, if you believe in shared decision making, then there's another term that I incorporate into my practice, which is what's referred to as patient-centered fertility care. I remember as a medical student learning about patient-centered care in a general sense, and it's always been part of my modus is to try and look at cases not just through the lens of the medicine, but how the medicine is impacting the patient and their unique experience. So patient-centered fertility care is definitely an aspect of our practice. More specifically, we do, although we are a large clinic, probably one of the largest in Canada, we do still subscribe to the one-on-one doctor to patient experience. So even though I have a practice where we cross cover, ultimately I have a roster of patients that I will take care of just like my other colleagues will. And so there's a bit more accountability. And I would say that's a unique piece of our practice. It's not always the easiest because it requires a little bit more work on our end, but I think the satisfaction shows through. Lateral thinking and open-mindedness. So not always just looking at a case, again, as you said, it's not just endometriosis. There might be other components to it. There might be a change in focus. There might be other ideas that a patient has. Maybe they read an article or paper, or they have a friend that used different treatment. You want to check your ego as a physician. You know, just because you didn't think of it doesn't mean that there aren't other ways of approaching this. I always tell patients, I know your case very well, and I know a lot about the medicine, but you know your case the best. And if there's something that we didn't look at closely enough, or you're second guessing, we can always re-examine it. And that doesn't just apply to clinical lateral thinking and clinical open-mindedness, but also in research. When you're working on research, when you're working with the university, it does push you to go to the edge of the medicine, of technology, of what's new. On a regular basis, my colleagues and I travel all around the world learning and adopting new research and clinical techniques. We send staff, we sponsor staff to go and teach, and we go as well. So I think that really helps, because we do live in an amazing country and an amazing place, but and I love Canada, but there's a lot going on in the world, and we want to learn about that in the fertility world. We are a full service clinic. So when I meet a patient and they have a unique set of clinical issues, I rarely look at the patient and say, I can't help you. I mean, they may not like or want to do the options that I'm offering, but I feel that as being a full service fertility clinic, meaning we can help females, males, same-sex couples, single individuals. We can help people from outside of Ontario borders, outside of Canada, and we have an experienced lab as well as support staff. So I really do feel that I have all the tools I need to help people. And then the final piece is, even though I've mentioned that we are very heavily involved in global fertility medicine and we're out there, we are Canadian. And I think during these difficult times, I'm so proud to be a Canadian physician with Canadian staff, supporting Canadian jobs and making more Canadians. I think that's an incredible, incredible attribute of our clinic. There are some clinics that I think are supported by other non-Canadian entities, and I'm just happy that we are where we are.
Yeah, definitely. I completely agree with that. And then last question here before we jump into some of our community members' questions. There is one common fertility myth that you could bust. What would that be?
Well, let's be clear. There are many, many myths, and we could have a whole session on the myths
For
of
sure.
fertility. The way I would answer that question would be, first of all, there are many myths, so it's not just one. If you think there's only one myth, then that's a myth in and of itself. But I would recall the reproductive physiology and the core factors. So very often people think of fertility as, if my partner had a pregnancy before, then there's no need to test them. And unfortunately, I often see it because I'm also a gynecologist. So a female will present and then say, oh, well, my partner has had a pregnancy before, has had a baby, therefore there's no need to look at them. And I would say that's a myth. I would say that you always need three things to make a baby. You always need eggs, you always need sperm, and they have to connect.
Yeah.
And so I think that the myth is that previous fertility makes you immune from any future fertility issues. And along that is only focusing on the female. I see that as well, which I think is a common myth. So, but we could have a great session just on Mythbusters. But that would be the one I would most focus on. That if I had a baby before, I'm not going to have a problem making a baby again.
I definitely agree with that as well. That's one I've heard quite a bit. But again,
we
let's
actually
cover
have
the education.
We actually have a technical term for that. So just a bit of an education piece. So when patients come to see us that have never been pregnant, like the female or the male, we refer to that as primary infertility. But if someone's been pregnant before, we use the term secondary infertility. And there's a lot of overlap between primary and secondary fertility, but there's typically an extra question we ask, which is, what's different now? Like what's going on? And so if someone doesn't embrace that thought that there could be something new, you're falling into that myth trap. And I see a lot of patients that have regret because they didn't seek out attention earlier because they thought that they would be fine because of their previous pregnancy. So it's a great, great question to look at.
Well, we received quite a number of questions from our community, so we'll try to get through as many as we can in the time that we have. So this member says, I have lost both tubes. Do I still stand a chance to give birth again?
So what I'll do is I'm going to answer the questions in two ways. I'm going to give the short answer, and then I'll start touching on a longer answer. Okay, so let's look at that question. So the question you asked me is, I've lost both tubes. Do I stand a chance to give birth again? And the short answer is yes, you do. In fact, one of the first applications of IVF treatment, which is one of the forms of advanced reproductive technologies, was for blocked fallopian tubes or people with tubal issues. So there's, in fact, if you watch Netflix, there's a documentary on IVF called Joy, and it talks all about that first generation of IVF providers and patients, and that was one of the first reasons. But again, it's a one-liner question. There may be other factors involved.
Yeah.
It's implying that it is a secondary infertility case, that someone's been pregnant before, now want to get pregnant again. So there are some pieces of that have to be unpacked. But my short answer would be yes. But I will say you probably should seek out a consultation on the sooner side so you can understand the full list of options, because sometimes the options are not IVF. There are surgeries that can be performed depending on the type of tubal issues that were done. I mean, sometimes the tubes have been removed, sometimes the tubes have just been interrupted. So you'd have to clarify that. But I think that's would be very appropriate to have consultation with someone like myself, like an IVF physician.
Awesome. Okay. Second question that we have here is it really true that fertility declines due to age for both men and women?
Again, the short answer is yes. For yes, and yes. So the first part of the question, is it really true that fertility declines due to age? On females, it is very true. Like, we have lots of evidence that supports that. But what people fail to grasp is that there are certain ages where you can still get pregnant. It's just more difficult to do that. And then there's certain ages where it probably is not possible with let's call it standard treatments. Obviously, there are other technologies that we have that are beyond this discussion to help people that may want to consider using, again, like donor eggs or donor sperm. But in general, I think that's a safe statement to support that fertility does decline with age. And then for both men and women, well, the evidence for women is very well established. Again, it doesn't matter which population you look at around the world. We know that reproduction does the fecundity and ability to conceive reduces. For men, it's a newer concept, and I think that's part partly because we're seeing more and more women that are trying to make babies at an older age. So since we're going to see older men, it's not as clear cut as the female discussion.
Okay.
So all my comments are going to end with, I think you should see have a consultation with a provider so they can give you the full answer. I will say though that the risk for men to conceive at an older age is probably not as obvious and clear as for women. Like meaning there's suggestions that sperm for men in their fifth and sixth decade, in their 50s and 60s, might have some downstream genetic problems, but it's not something that is a contraindication. Like I would never say to a male, because you're 50, you're not allowed to get pregnant. We might just consult them a little bit in a little more deep fashion.
Yeah. And I think from my own personal research too, it's the same thing I found. You find a lot of research on female fertility declining due to age, and just a handful when it comes to men. But it's nice to know from you who's working with those patients.
I mean, if you really want to dive into the research, what we've seen is that for females, it's directly on the child, right? Like meaning we know that as women get older, they have more difficulty conceiving and they have higher miscarriage rates and higher rates of abnormal embryos, which are all mostly a function of the egg. With men, what we see is not necessarily in the immediate offspring, but in the grandchild and the subsequent generation. So we see like the grandchild, like it's sort of in what we call an epigenetic fashion, like meaning generations down the road, we see that kids may have other issues when they have an older grandfather. So that's a little bit far for some people to worry about. And only now are we seeing that because people weren't living that long to experience it. So it's an area of research that we're looking at really closely. But for the most part, I would say, and I think you were going to ask me a bit about supplementation. For guys, one of the best things they can do is be on a multivitamin. Any multivitamin, it can help with sperm health and reducing those factors that drive the epigenetic impact.
Awesome. And then still on that topic of supplementation, are there any specific diets or supplement recommendations you can make for someone who's looking to improve their fertility?
Well, I mean, in terms of diet, usually diet, supplements, and lifestyle all get lumped together. So whenever I meet a couple or individual that's trying to conceive, I always ask them to do an audit of their other health issues, and that has to do with them, their own healthcare team before they meet me. So making sure that if they have habits like excessive drinking or smoking or drug use, that they eliminate or significantly curb it. And that also applies to any other medical conditions. If they have high blood pressure or diabetes or depression or some other condition, that they're on the right medications for pregnancy and that they optimize that condition. What if they're on a cholesterol pill? Like some of these medications, there are alternates that are okay for pregnancy, and some of them you shouldn't even be on. So that's even before they're on a supplement. For women, there's pretty good evidence that you should be on some form of folic acid as well as a multivitamin. We typically also encourage calcium and vitamin D and omega, those are fish oils. So there are these vitamins that you can purchase that are maternal vitamins. So they're already kind of organized, so you don't have to worry about picking each one. And there are also some products out there that you can subscribe to on the internet that are well validated that will send you supplements on a regular basis while you're trying to conceive. For men, other than the multivitamin, I mean, there are male fertility vitamins. I just would be careful because some of them are mislabeled as enhancement. So those could actually reduce fertility. So I would just say read the labels very carefully, speak with your provider. And again, if you are planning pregnancy and you're not sure, I think booking a non-urgent consult will be very helpful.
Definitely. So you can get some answers to some of those questions. And
as well, I always tell people that you're not in this on your own, right? You have multiple resources around. You have your family healthcare team. You might have your specialist, your infertility specialist. You also might want to have a naturopath or a nutritionist because they're experts in supplementation and diet, and they could provide even deeper insight into the do's and don'ts and what's most appropriate.
Awesome. So, fourth question here. This community member says, Endo Warrior here. Can you explain how endometriosis impacts my fertility?
Well, there's the short answer, which is if it was a yes/no question, yes, endometriosis does impact your fertility. And then how? Well, that's a longer answer, and I would just answer in many ways.
Mm-hmm.
We know a few things about endometriosis. We actually just passed Endometriosis Awareness Month, or I think we're in it, like we're at the tail end of it.
Yeah.
So it's a very hot topic. A few key points about endometriosis. So first of all, to establish diagnosis, you would need to see a specialist, have an ultrasound. Some women actually will go for special surgeries called laparoscopies or get an MRI to determine it. But you'd want to first be diagnosed with endometriosis before you worried about it. And then once you were diagnosed with it, you would have to decide really what is the priority, because endometriosis patients usually have two big experiences. Either they have lots of pelvic pain and discomfort and issues with their periods, and so they need relief from that, and there's a whole approach to managing it. Or
Mm-hmm.
they say, no, I don't have so much pain, but I want to make a baby. And someone told me about endometriosis. What do I do? So we have to pick the pathway that we're going down. And then the other thing we have to appreciate is that the relationships between endometriosis and fertility are not causal, they're associative, which means there are many, many women with endo that will never see a fertility specialist.
Mm-hmm.
And there's a set of fertility patients that coincidentally have endometriosis. So there's some overlap with them. And also there's a group of women who have terrible pelvic pain that don't have endometriosis.
Yeah.
And there are women with endometriosis who have pain, we don't see the endo, or vice versa. So I would say that it's a very enigmatic, it's a puzzling condition.
Mm-hmm.
It may be part of your therapeutic pathway, like there may be a role for treating it, but I wouldn't be surprised if there are many specialists that say, you know what, let's focus on getting you pregnant. And maybe just that alone will help your endometriosis. So I go through this back to the shared decision making. This is a classic example of what I'll discuss with patients in terms of their ultimate endometriosis treatment. And very often they will bounce between the surgical gynecologist and myself to co-manage the case so that we can get
Mm-hmm.
everything. We can have a happy patient with pain relief as well as preserving their fertility or helping them make a baby.
Yeah. Amazing. I definitely learned a few things there, especially about endometriosis and some of the symptoms that might present for patients. So our other member here says, I am a 42-year-old woman. My fiance and I have been trying naturally for around 6 months. I'd like to understand what our chances will be to have a child. Should we keep trying or be exploring our options at this point?
Okay, so I'll answer the first question. So in short, the answer is low. If you are trying in an unassisted way, relying on your monthly cycle, you might conceive, but it will take you probably many, many months to conceive, like it would
Mhm.
for any couple, but longer in the over 40 category. I think you also have to compare that to what would happen if we used reproductive technology.
Mhm.
Then your chances of success would be significantly higher, all things being equal. So any patient over 40 that wants to make a baby, we would agree to see them in consult. It doesn't matter where you live, where you are. I would seek some form of consultation
Mhm.
even if it's a virtual consult, even if you live in a place where they don't have advanced technology, just to
Yeah.
fully understand the choice of trying naturally versus other options. Because
Mhm.
very often I do meet people that have a lot of guilt over decisions that they made or false hope that they were given. So and based on what I know of you, I don't know enough to say how low, but even if you're the best 42-year-old on earth, uh, we could do better. And so that would be my answer. And should we keep trying or exploring other options? Yes, and yes. You should keep trying because as long as there's no major issues in your medical history, as I said, you may conceive. But in parallel, I would explore other options because those options are probably still available in most parts of the world. At some point, though, they may not be. Even if you say, I've got all the resources, I've got all the desire, I want to use the technology, at some point, the doctors may say, I'm sorry, the only option is something that you may not really want. So
Mhm.
my take home is keep on trying, but book a consult with
Yeah.
anybody.
Yeah. I think that's definitely the best path forward there. Um, this next person says, someone I know froze her eggs last year and shared it on social media. Since then, I have researched all about egg freezing and read about it on Reddit. I'm not sure if it's a good time for me. For context, I'm 32 without a boyfriend. Will it be difficult for me to give birth at, let's say, 36 or 37 if I don't freeze my eggs now, assuming I meet someone before then? Thank you.
Okay, so there's two questions there. I broke it up as I'm not sure if it's a good time for me for egg freezing at 32, and I would say it is a good time. Again, at least to have the consultation. Depending on where you live, I mean, many areas there's no charge for a consult, so
Yeah.
you can meet with someone just to learn about what the numbers are. And the irony is that younger women are being told, well, you're young, you got time, and that's true, but you won't be young forever. And then at some point, if you do come back later and you're in the same situation, egg freezing is that much more difficult,
Yeah.
right? Egg freezing is not as efficient when you're in your mid 30s versus your early 30s. The
Mhm.
challenge is there's a lot of resources required for egg freezing, medical resources, emotional resources, and financial resources, and they're just not always available to women. From experience, the sweet spot for egg freezing for us is around 34 to 38 years old, because usually
Okay.
those are people that have been working for a bit more. They're out of their school years, they're professionals, or they're working in jobs where they have a little more status, and they've explored partnering or doing this on their own. They're just not ready.
Mhm.
So that's, I would say, like the wheelhouse for it. But I've met women in their 20s, mid 20s, late 20s, even into their late 30s and early 40s. The challenge just is how efficient will the egg freezing process be at that point. So to answer the second question, will it be difficult for me to give birth at say 36 to 37 if I don't fuse my eggs now? It really depends. We don't know enough about you. The average age of consult in my office is about 38 to 40. So we're seeing a lot of women older than you. We don't know what situation you'll be in at that point. Like maybe you'll have a partner, maybe you'll be coming as a single female, maybe you'll be in a same-sex relationship. But if you say, with what I know about you, can a 36 or 37-year-old get pregnant? Absolutely. But what if you want to make a second baby or a third baby? Very often people think about egg freezing as what they need to do for the first baby. And that may be the case. But as I said in the beginning, my job isn't just to make babies, it's to build families. And what if you want to have a larger family? Right? What if you really always wanted 2 to 3 children?
Yeah.
So I think the person that's thinking about fertility, the person that it's clearly on their mind because you took the time to write the comment, you're following BFA, you're following me through this process. I would firmly support a consultation, and there's many ways that consult can occur. At least in our practice, we have general doctors, we have nurse practitioners, we have professionals like myself, whatever you're comfortable doing. But the internet may not be sufficient because you might not getting the specific answer for you, that patient-centered response.
Mhm. Absolutely. And then coming up to the last question from our community here, this person says, my older sister has fibroids. I have PCOS. What can we do to ensure we can have kids when we are ready? She's 32 and I am turning 29.
So thank you for that question. That's definitely a question that I would start by saying consultation, because back to my earlier comments about how whether it's fibroids or polycystic ovary syndrome, PCOS, or endometriosis, there's going to be two sides to it. Like
Mhm.
clearly, if you know you have fibroids or PCOS, something has been going on. In the
Yeah.
case of fibroids, maybe there's been issues with pelvic pain, bleeding, and you've had to see a general doctor or gynecologist to understand what your options are, whether they're hormonal or surgical. But there's another side to that. There's the fertility side. And
Mhm.
similarly with the polycystic ovary syndrome, you likely either had skin or hair changes or irregular cycles when your period started, or flooding or no periods. And so there's issues there around cycle control as well as contraception if you don't know when you're getting your period
Yeah.
and you're in some type of relationship. So um, the well woman side needs to be put against the fertility side. We have to decide what is driving the priority set here. So
Mhm.
that's very much a consult type of question, because each of you, although you have common anchors like fibroids and PCOS are amongst the most common things we see, the way they impact a 32 or 29-year-old are, there may be some similar features, but they're still distinct and different, right? Like 29 is well within that high prognostic group. 32 is approaching our second prognostic group, which is the 32 to 35 age range. And so I would probably want you both to be evaluated, full history, ovarian reserve assessment, ultrasound to see where these fibroids are located, to understand is the PCOS associated with diabetes or hypertension. So there's a lot of opportunity here. In terms of what you should be doing, though, is taking care of all the other things that you can. Living a healthy life, not smoking, limited alcohol, no drug use, managing other issues like hypertension, because very often with PCOS, there are what we call comorbidities. So these are both women that should see their family doctor on a regular basis. And again, do a bit of an audit of what is their main problem and what are they worried about most.
Awesome. I think to sort of summarize some of the answers that we've gotten from you today, Dr. Baratz, it's making sure people who might have some of these questions, knowing that they have the option to go and have that consult, be it with their family doctor, be it with a specialist, just so they can get an answer to their specific situation and find a path forward for them.
Yeah, I would agree. I mean, I would say that many of these search terms, like if you just search fibroids, it would be, even with all the advanced technology and the advanced search engines like ChatGPT and all the AI, it's still not good enough, and the algorithms aren't good enough, and you haven't done enough testing to pump into the algorithms what your answer should be, right? Yeah. And your answer may be to not do much at all, right? But that's my take home, is that women and men that are concerned about their future fertility, because if you're not concerned about your future fertility, these issues are just about managing your comfort and your lifestyle and being well. But if you are, having some of these conversations with people that can provide the answers, or at least touch on some of the topics, would be very, very helpful for you. And these are not emergency consults, right? These are not things that you decide today and have to be booked tomorrow. These are things that can happen in non-urgent to us, like 3 to 6 months down the road. But I do want to be very clear that even though I'm a fertility specialist and I deal with infertility, just because you have PCOS or fibroids endometriosis does not mean you can't conceive unassisted. So I would never want someone to leave this conversation without having to say, oh, Dr. Baratz said I have these issues, I'm never going to get pregnant. I'm not saying that at all. In fact, all of those conditions are still consistent with unassisted conception. My point is, if it's not happening after a certain amount of time, you should look back at those labels that you were given and say, hey, this might be associated with fertility. I should go see Dr. Baratz or someone like that. That's really my take home.
Awesome. Well, thank you, Dr. Ross. That kind of brings us to the end of our interview here. Thank you so much for your time. We really appreciate the work that you do, and being here to answer some of these questions for us.
Can I come back?
100%. I would love to have you back, especially to answer some of those questions around those fertility myths. I think that would be great to sort of have a whole conversation on busting those myths.
Yeah, maybe you could get even a few. You can get a panel together and see how they would get a little head-to-head going on, seeing like a few people giving their comments on it. But yeah, I think having a session dedicated to myths would be very helpful, and having that conversation continuing, meaning people should feel comfortable talking about their fertility. There are a lot of cultural, I would say, myths as well about what's normal, what's not normal, and when to worry and not worry. And I think there's some people that are maybe more worried than they should be, and there's some people that aren't worried enough. So try to get an objective opinion from a professional. It doesn't matter which professional it is. Like I said, it could be a naturopath, holistic physician, family physician. It could even be the BFA, because your organization is now gathering information and is becoming a valuable resource. And there are other resources too. Patients should be, at least I can mention some of them. There's Fertility Matters Canada is a great resource. Health Canada is a great resource. There's Society of OBGYNs of Canada is a very good resource, as well as the Canadian Fertility and Andrology Society.
Awesome. Did you know we're partners with Create Fertility Center? If you'd like to explore your options with Dr. Baratz, please fill out the intake form in the description, and someone at BFA will get you started. Don't forget to like, share, leave a comment below, and most importantly, subscribe, and we will see you in the next interview.